And Venki, I guess, because I'm a cardiologist, wanted to embarrass me. So he asked me, try to find a case where you did some harm anyhow. And so this is a long time ago, and probably 7, 8 years ago. I had to look very hard to find a case like this. So I have nothing to disclose other than I did harm on this patient. So this is an 88-year-old female that presented to us with swelling in the neck on the right side, difficulties in swallowing and hoarseness. And she had an outside study where a CT was done that revealed a large proximal internal carotid artery aneurysm. Actually, you could feel it pulsating. Half of it was maybe under the angle of the jaw. And because of her comorbid conditions, she was not considered a good surgical candidate, so she was referred to us for endovascular repair. And so we did this in neurointerventional suite with Dr. Michael Mawad that had tremendous experience in those type of procedures. And this was done under general anesthesia because most of the neurointerventional radiologists do it under general anesthesia, and there's a good reason for it because you have to be able to see the anatomy at the end of the procedure. The patient has a complication and it moves around. You cannot identify where the problem is, and you cannot rescue that patient. But as you can see, this is extremely challenging anatomy as far as denominator is concerned, a lot of tortuosity there. And here is the aneurysm, as you can see it. Again, a lot of tortuosity. So we worked on similar cases, maybe 10 or 15 cases like this, with a variety of different approaches, but this one we were doing actually in a live demonstration case during one of our symposia, and we thought that we could do it. So we heparinized the patient. We used a 8 French sheath from the femoral artery access. We used a VTEC catheter because of the tortuosity there. Use a glide wire to enter into the external carotid, exchange it for a stiffer wire. Then we put a 4 French glide catheter there, with Amplett's wire and shuttle select sheet all the way to the bifurcation to get adequate support. So in the past, this is just one of the examples. This is what we're trying to accomplish. Either you coil embolize the external, and then you could put a bare metal stent, and you could put a balloon and onyx. All kind of scenarios exist. But we were planning to do a self-expanding stent, and Viaband and Fluency was available at that time. So this is when the trouble started, and actually we're supposed to go live exactly at this moment when we had a wire in the aneurysm across the lesion, and we're trying to advance the protection device that was available at that time. It was impossible to do it. So we said, let's go back to the presentations. So they kept calling us, are you ready, are you ready? So about an hour after that, we were ready to show that we were not ready. So here are all the things that we try to do. Any kind of scenarios that you could imagine, changing it to a stiffer wire, trying a Viaband. We try a flow diverter, but after about an hour and a half, which is way past what you should do actually, but that was the reason for doing the live case, but I would never pursue it otherwise. We aborted the procedure. So the patient was intubated under general anesthesia, and we performed the intracranial angiogram. We didn't see anything new. We did a pre and post, and they look exactly the same. So we said, well, no harm is done. But when the patient was extubated in endovascular suite, she was extremely restless, confused, combative, and was not able to move her left leg and left arm. So we knew there was some trouble there. So as I showed, we didn't see anything on the angiogram, but a CT later showed right multiple small hemispheric infarct. This was more than what you see on DWI, and with any technology and techniques. So she was in neuro ICU, and she had prolonged rehab and finally ended up in SNF. So I wanted to share with you, all are very familiar, there are issues and problems and complications that occur with type 2 or type 4 arch, extreme vessel tortuosity, severe calcification, tandem or multiple lesions, like what Dr. Zir has shown there, and so on. String sign is another contraindication in my mind for carotid artery stenting. Presence of a thrombus, like you can see on the right-hand side. Aneurysms, as we have seen that, recent ipsilateral stroke, or failure to access the lesion in 20 minutes in my criteria, and then renal failure and congestive heart failure. Now, so the reason for embolization was exactly what we caused in this particular patient. It's not necessarily poor technique, but being desperate to do something what you were not supposed to do, or not using cerebral protection device, or have a very excessive debris that overwhelms the current generation neuroprotection devices. Pre-dilatation with the large balloons, very aggressive pre-dilatation, multiple dilatations for one reason or the other, and like in our case, forcing the wire balloon or stent across the region, rigid or very tortured aneurysmal lesion. Post-dilatation with oversized balloon, as Venki said, he rarely does that. So then what do you do in this type of a scenario when you cause trouble with embolization? Well, it's easy to do it for a neurointerventional skilled physician when you see the lesion. But when you don't see the lesion, that's another problem, obviously. So typically, it's a distribution of middle cerebral artery or its branches, but small branches are difficult to actually do any kind of intervention on. So you monitor a patient well during every step of the procedure, and you optimize everything that you can, blood pressure, heart rate, oxygen saturation, check your ACT. And one important thing is do not abandon whatever you intended to do. If you can do it, you have a stent across, deploy it. Don't remove it if it's technically feasible. And use intracranial rescue techniques when you can. So those are the things that exist, but in our patient, we really didn't have choices.
Gotcha.